back. So we have started the preparation for obstetrics subject, and we have covered the highlighted topics. These are up till fetal distress. We have covered all the topics up till fetal distress. Now in this video we are going to discuss the intrauterine death and the rest of the topics. These topics are remaining in obstetrics, so we will cover these topics one by one. Okay, so coming towards the today's topic, that is intrauterine death. So for intrauterine death, we are having a scenario that there is a 25-year-old PG presents to antenatal clinic with 38 weeks pregnancy and intrauterine death. The HB is 8 gram per dm. Another scenario is that there is a diabetic with intrauterine death and defined stillbirth and the causes of stillbirth, and multigravida with intrauterine death and previous bed obstetric history and brought to labor room. G4P3 at 36 weeks pregnancy with loss of fetal movement, ultrasound confirmed intrauterine death. Okay, so what are the causes? We have questions of intrauterine death in this pattern, so we will discuss all the things about the intrauterine death one by one. Intrauterine fetal death after the viability stage and before the delivery is known as intrauterine death. Whenever there is death of the fetus after the period of viability, it is intrauterine death. If it is before the period of viability, that is 24 weeks, then it is miscarriage. So this is intrauterine death. What are the causes? These are maternal diseases, which are diabetes, hypertension, any disorder causing septicemia with hyperperfusion, obesity, renal diseases, uterine anomalies, blood diseases, and old age. These are the causes of the intrauterine death. The fetal causes are fetal malformation, that is structural and chromosomal, infections, that is bacterial, viral, and TORCH, fetal immune hemolytic diseases, metabolic disorders, and cord accidents. Okay, TORCH are the different infections or bacterial, viral, and okay, now the pregnancy. In pregnancy, pre-eclampsia or eclampsia. Page number 69. Okay, here it is. So these are the fetal causes. Now the pregnancy. In pregnancy, pre-eclampsia, eclampsia, abruption, smoking, drugs, and trauma are the causes of the intrauterine death. Now the diagnoses are that decrease or absent fetal movements are present, loss of the fetal heart sounds is present, CTG is abnormal, and it is confirmed by ultrasound. The management options for intrauterine death are that first of all, initial management is done. It is aimed at finding the cause of intrauterine death to help in the management of future pregnancies. Then history is taken of hypertension, diabetes, high-grade fever, drug intake, economic states of the patient, previous or family history, and congenital malformation. Then examination is done for pallor, BP, uterine tenderness, fundal height, fetal presentation, and liquor volume. Then Bishop score is assessed to determine the mode of the delivery. Then breaking the news by taking one of family member in confidence, and investigations are done which are FBC, HB, blood group, sugar profile, and glucose tolerance test, and serology is done which is urine analysis, and X-ray, Spalding sign, and Robert sign. Spalding sign is overlapping of the skull bones, and Robert sign is the presence of gaze shadows in fetal circulation system. Now the coagulation profile is done which is degree fibrinogen, and ultrasound is done for malformations and liquor volume. Then how and when to deliver. So the conservative approach is done and induction of labor is done. The conservative approach is that if induction of the labor is not advisable, then conservative approach is followed, in which the patient is followed up regularly. Coagulation profile is repeated every week, and coagulopathy can be treated by heparin. The induction of labor is done by prostaglandin, oxytocin, and artificial rupture of the membrane. And the mechanical methods are sweep and stretch, and Foley's catheter is used, and complications are DIC, that is coagulopathy, and psychological stress. So we have discussed the topic, the intrauterine death, which is a small topic, and we have discussed the causes, which are maternal diseases and fetal causes, and the causes during pregnancy, which are pre-eclampsia, eclampsia, abruption, smoking, drugs, and trauma. Then we have discussed that how it is diagnosed, and then we have discussed the management, which is initial management, history taking, examination, and Bishop score. Then breaking the news, and then the specific investigations are done, and it is calculated the how and when to deliver, and how the conservative approach is done, the induction of labor, and what is the mechanical method, and what are the complications of the intrauterine death. Now coming towards the intrauterine growth restrictions. So we are having that fetal growth restriction. Intrauterine growth restriction is fetal growth restriction, and it is the failure of a fetus to achieve its genetic growth potential. This usually results in a fetus that is small for gestational age and small for okay. It is for the fetus who is small for gestational age. Now, the small for gestational age means that the weight of the fetus is less than the 10th centile for its gestation, and intrauterine growth restriction indicates that there is a pathological process operating to restrict the growth rate of the fetus. Now, the causes are reduced fetal growth potential, that is, implied, for example, trisomies and single gene defects, structural abnormalities, for example, renal agenesis, and intrauterine infections, for example, cytomegalovirus and toxoplasmosis. Then reduce fetal growth support and maternal factors which are undernutrition, for example, poverty and eating disorders, maternal hypoxia, living at altitude, cyanotic heart disease, and drugs, for example, alcohol, cigarette, and cocaine. Then we are having the placental factors, that is reduced uteroplacental perfusion, for example, inadequate trophoblasts, and okay. So the placental factors are reduced uteroplacental perfusion, for example, inadequate trophoblast invasion and sickle cell diseases and multiple gestations. They reduce fetoplacental perfusions, for example, single umbilical artery and twin transfusion syndrome. Then pregnancies at risk are multiple pregnancies, history of the intrauterine growth restriction in previous pregnancy, heavy smokers, drug users, women with underlying medical disorders. Then the management options are initial management, that is, it is aimed at finding the cause or risk of intrauterine growth restrictions. Then the history of hypertension, diabetes, high grade fever, gut intake, chronic infection, menstrual history, previous family history of congenital malformation. Then examinations are done for the pallor, BP, fundal height, fetal presentation like a volume for stigma of the chronic disease. Then investigations are done which are baseline investigations and brief detection of the small gestational age, that is finding the accurate assessment of the gestational age and recognition of the fetal smallness. Then gestational age is early measurement of the fetal crown rump length before 13 weeks plus 6 days of the gestation, or head circumference between the 13 to 16 and 20 weeks of gestational age. Ultrasound is a diagnostic tool of the choice for intrauterine growth restrictions. A detailed ultrasound is carried out for fetal biometry, abdominal circumference, biparatal diameter, head circumference, amount of the lichen, and rule out the anomalies. Then Doppler ultrasound is done for fetoplacental and uteroplacental circulation. Biophysical profile is done, CTG is done, karyotyping is done, which is the examination of chromosomes, and amniocentesis is done for fetal abnormality. Now, the treatment options are that contributive factors such as alcohol, small drug, smoking, and drugs should be stopped, and low dose aspirin, which is role in the preventive of fetal growth restriction in high risk pregnancies. When growth restriction is severe and the fetus is too immature, these are the treatment options. Contributive factors such as alcohol, smoking, drug abuse should be stopped. Low dose aspirin may have role in the preventive of fetal growth restrictions in high risk pregnancies. When growth restriction is severe and the fetus is too immature to be delivered safely, bed rest hospital is usually advised in an effort to maximize the placental blood flow. The aim of these interventions is gain much maturity as possible before delivery to reduce the morbidity associated with prematurity. The mode of delivery is vaginal delivery, C-section, and induction of the labor, and the time of delivery is according to the gestational age, fetal viability in the setup, and in utero transfer in tertiary care unit. So we have discussed the topic, the intrauterine growth fetal death, and we have intrauterine growth restriction. We have revised the intrauterine death already. So the intrauterine growth restriction, and what is the fetal growth restriction, and what is small for gestational age, and what is intrauterine growth restriction, and what are the causes. So these are the reduced fetal growth potential, reduced fetal growth support, and maternal factors and placental factors. Then what are the pregnancies that are at risk of intrauterine growth resistance, how we will manage. So first of all, the initial management is done, then history is taken, examination is done, and investigation is done, and the gestational age is checked, and the ultrasound is done. The Doppler ultrasound and the biophysical profile, the CTG, the karyotyping, and amniocentesis. These are all the investigations that are done to check the fetal well-being. Now, the treatment options are, first of all, you have to contributing factors such as alcohol, you have to stop that contributing factors. Then what will be the mode of delivery? These are vaginal delivery, that is C-section, induction of labor. Then what is the time of delivery? According to gestational age, fetal viability is in the setup, in utero transfer, and tertiary care unit. So this is the intrauterine growth restriction, and all the causes management is discussed. Now coming towards the next topic, that is amniotic fluid abnormalities. So we are having the amniotic fluid abnormalities as oligohydramnios and polyhydramnios. Oligohydramnios are too little amniotic fluid, that is amniotic fluid index less than fifth centile for gestation, and clinically it is defined as volume of liquor which is pathologically low for its gestational age. Now the causes or risk factors of oligohydramnios are preeclampsia, placental functional compromise, drugs that is NSAIDs and angiotensin converting enzyme inhibitors, and urinary tract abnormalities or obstruction, and fetal growth restrictions, and fetal anomalies which are renal agenesis and renal development of defect and polycystic kidneys, then prolonged pregnancy and premature rupture of membrane. The management is done as the diagnosis. First of all, history is taken, history of the clear fluid leaking from vagina. This may present premature rupture of membrane and reduce fetal movement. Then examination is done which shows the presence of associated conditions, BP and edema. Then per abdomen height of the fundus lesser than the gestation period, the fetal poles may be very obviously felt and hard with a small for dead uterus. For the Okay, the investigations for oligohydramnios are ultrasound, that is amniotic fluid index scan is done and fetal anomalies are checked. In amniotic fluid index scan, the amniotic fluid index is an ultrasound estimation of amniotic fluid derived by adding together the deepest Okay. So the amniotic fluid index scan is an ultrasound estimation of the amniotic fluid derived by adding together the deepest vertical pool in four quadrants of the abdomen, and the Doppler may be useful in diagnosing reducing placental perfusion. The specific measures are amniotic infusions, that is amniotic fluid to introduce, and termination of pregnancy of fetal anomalies, and CS if fetal anomalies are excluded, and amnio infusion and vaginal delivery. The prognosis depends on the underlying cause, associated factors, the fetal anomalies, and the gestational age, and the mother, that is the increased risk of C-section and fetal malformation, intrauterine death, cord compression, and fetal lung hypoplasia. So we have discussed the we have discussed the amniotic fluid abnormalities, that is the oligohydramnia. So it is the little amniotic fluid, and what are the causes or risk factors for it, and what is the management and the diagnosis, that is history taking and examination, and then the investigations which are ultrasound and FFI scan, that is amniotic fluid index scan, and then the specific measures, and then the prognosis. Now coming towards the next topic, that is polyhydramnias. So we are having a scenario that there is a G2P 136 weeks pregnancy with polyhydramnias. Define polyhydramnias and what are the complications. So polyhydramnias is the excess of amniotic fluid, that is amniotic fluid index greater than 95th centile for gestation or ultrasound estimation. The causes are overproduction of the fluid or impaired swallowing by fetus. Then we have the maternal, the placental, and the fetal causes. The maternal are diabetes mellitus and Rh isoimmunization and syphilis or cytomegalovirus infection. The placental causes are chorioangioma and arteriovenous fistula. The fetal causes are multiple gestation and idiopathic and esophageal atresia, duodenal atresia, neuromuscular fetal conditions, and anencephaly. The complications of polyhydramnias are premature rupture of membrane and cord prolapse and placental abruption, preterm labor and hypotonic uterine incision, intrauterine death, and PPH, postpartum hemorrhage. The management options are history taking, that is, it may present a severe abdominal discomfort and swelling. On examination, the abdomen will appear distended out of the proportion to women's gestation, and the abdomen may be tense and tender, and the fetal poles will be hard to palpate. The investigation options are ultrasound abdomen, that is to rule out the amniotic fluid index and the fetal anomalies and confirm the gestational age. Then the fetal karyotyping is done and the maternal lab screening is done. The treatment options are mild treatment, that is reassurance, and it needs symptomatic treatment and rest and analgesics. Endomethacin and solinadec reduces fetal urinary output and decreases amniotic fluid. Then the moderate to severe are therapeutic, that is amnio reduction drugs, and the management of the polyhydramnias is directed towards establishing the cause and determining the fetal prognosis, relieving the discomfort of the mother, assessing the risk of the preterm labor due to uterine overdistension, and if prior to 24 weeks then following amniotic fluid drainage the cervical length is less than 25 cm centimeter, and consideration might be given to cervical suture insertion. If polyhydramnios is due to maternal diabetes, then it should be corrected by maternal diabetes control. And twin to twin transfusion syndrome, that is amnio drainage removal by laser of the placental vascular connection, and the delivery at the 37 weeks is done, that is external cephalic version plus artificial rupture of membrane and induction of labor, and elective C-section is preferable. So this is the polyhydramnios. We have discussed the definition that it is the amniotic fluid greater than 95th centile for the gestation of ultrasound. Then we have discussed the causes, which are maternal, placental, and fetal. Then we have discussed the complications, the management, that is history, examination, and investigation, and then the treatment options, which are for mild treatment and moderate or severe treatment. And then we have discussed the delivery options for the polyhydramnios. In the next section of the video, we will discuss the antepartum hemorrhage and the placental abruption and the causes of the antepartum hemorrhage and other disorders or defects related to the OBS. Thanks for watching.